Okay, thank you, everyone. I will now turn it over to Dr. Catherine Monk. And when she is finished with her presentation, I'll be back for the response panel. See you soon.
Hello, everyone. And that's a very powerful film to come after. And I hope that the data that I present today will be part of what moves us forward in making change. And apologies also about the technical difficulties we had. So I'm going to be talking about distress in pregnancy, maternal and child effects. Next slide, please. I don't have any disclosures. Next slide, please. So I'm going to have some themes today. Next line on this slide. So much past inside my present. That is from one of my favorite pop singers. And the next one is from Cast, the really powerful book by Isabel Wilkerson. Next, please. With an old house, the work is never done, and you do not expect it to be. America is an old house. We are the heirs to whatever is right or wrong with it. We did not erect the uneven pillars or joists. They are ours to deal with now. Next slide. As individuals, families, communities, a nation, the past is with us. We are feeling the life and death urgency of a social justice movement as we try again to face and address our past, the legacy of slavery and ongoing racism in this country. You will hear the impact of the past in my talk related to childhood trauma, so that's on an individual level, and also in health disparities related to systemic racism. Next. So an overview. Next, I'm going to give you a list here, and we're going to have a dyadic focus, looking at the birthing person and the child. Next. Maternal mental health, of course, is a focus. Next, we're going to look at the allostatic load model. Next, another model in research called DOHAD, which I will define and look at stress and birth outcomes. And then finally, next, we're going to look at the implications for the prenatal care ecosystem. Next, please. So a dyadic focus. Next, please. Usually we think about the parent with the child after birth. Next. But in this talk, I really want to be looking at the birthing person and how they're doing before the baby's born, and then also the fetus, the child before they're born. Next, please. So that's the dyadic focus. Next. It's really maternal health and an emphasis on mental health, and then subclinical physical health, which I'm going to describe more. Go ahead, please. We're going to look at fetal and infant health, really specifically the birth outcomes. Next, please. So maternal mental health, go ahead. My chair of the department at Columbia Obstetrics and Gynecology, Mary Dalton, asked the question years ago, where is the M in maternal fetal medicine? That we've lost track of the woman when we're in our care with maternal fetal medicine, that dyad, really saying we need to focus again on the woman or excuse me, the birthing person. So we need that M in our maternal fetal medicine. And that's going to be true in what I'm emphasizing today. Next, please. Another ping. Thank you. Okay, I'm going to run through some data here that many of you are familiar with. 52% of birthing people report daily stress, such as job strain. Next, please. 65 to 70% report one or more stressful life events. That's a death of a close person or a major move during the pregnancy period. Next, please. 20 to 25% experience an anxiety disorder. Next, please. 10 to 20% experience perinatal depression, and those rates double for people in low socioeconomic conditions or also people of color. Stressors such as job strain, life events, racism lead to stress and can be a contributing risk factor for depression and anxiety. Next, please. And then when you're experiencing anxiety or depression, that lowers your coping ability or your threshold for what counts as really stressful, what gets you to feel overwhelmed. And that thereby can increase your experiences of something being really stressful. Next, please. Next. So stress and mental health conditions really have a bidirectional association. They each influence each other and unfortunately can build together so that people are experiencing both. Stress, depression, and anxiety deserve attention for the pregnant person, and they each can be associated with substance use problems. Next, please. How much and what level of stress, depression, or anxiety matters for birth outcomes is a question I'm going to try to answer in this talk. Next, please. So I wanted to quickly, a colleague shared with me these slides out of New York City, really looking at maternal mortality and morbidity. I'm going to be focusing on the mortality part. Next, please. And what I wanted to emphasize here, these are two different ways of counting mortality in the pregnancy period, related or associated, which is the larger category. Here we're seeing that the numbers, it's great, they're actually going down for maternal mortality in New York City. There's been a huge effort. However, next please. I'm sorry, not however yet. What I really wanted to emphasize here, no, that was me, go back to the pie, thank you, is mental health. Mental health is the largest contributing category for maternal mortality. And you can see that that's often, but certainly not always, overdose or suicide in the mental health category there. That's what leads people to death. Next slide, please. But this is the however part, is we have terrible disparities. So that Black versus white birthing people are almost 10 times more likely to die related to childbirth. And again, this is New York City data. Next slide, please. And this is really remarkable when we look at the top line there is live births. We're seeing that Black people count for nearly 20% of the live births. But the next two categories in that yellow shows you how much more of the pregnancy associated or pregnancy related deaths they count for. So terrible disparities in these outcomes. Next slide, please. And we really have to keep in mind that when we look at these mortality rates, they're independent of socioeconomic class. So here you see that when we go to the furthest right on the slide here, that this very privileged group of college educated or higher, that Black women are nearly 5 times more likely to die related to childbirth compared to white women. So this is really a disparity independent of socioeconomic status. Next slide, please. And then super important work from Dr. Elizabeth Howell, who's the chair at UPenn in obstetrics and gynecology, looking at different medical care at the same hospitals and still seeing that this is morbidity rates. So then what you have on the x-axis in the bottom there, #1 hospital and its ranking out to the 39th, you still see even at the best hospital, Black women are sicker there, implying they're not getting as good care. And the difference between Black and white is even greater when you go out to the less highly ranked hospitals. So we're seeing really some kind of systemic racism in care here. Next slide, please. So now I'm going to shift gears, keeping all of that background in mind, please, of how central mental health is to a pregnant person's well-being. But we're going to look at the allostatic load model. So stress, depression, anxiety, we can call those distress. They can also affect physical health and thereby potentially birth outcomes. Next slide, please. So this is a research model that came from the late Bruce McEwen, looking at stress, adaptation, and disease. Really, how can we understand stress contributing to disease conditions? And I'm going to add the condition of a poor birth outcome. Next, please. So he had this idea of allostasis, that this is an organism. We're all organisms, and we maintain a physiologic stability by changing our parameters to respond both internally and externally to environmental demands. Next, please. But the concept of allostatic load is the wear and tear on the body when over time you keep on having to have these allostatic responses in stressful situations, and the wear and tear on your body, these demands is too much. You have a high allostatic load. Next slide, please. What this next bullet, I should say, is that this really relates to social determinants of health. So what demands you have on you, whether it's food insecurity, racism experienced at the job, et cetera, these are activating your body to need to respond to those stressors. And if it's overload, if it's too much, your allostatic load is going to be very high with consequences for your physical health and possibly birth outcomes. Next slide, please. So here's a visualization on the top of, an ideal stress response. We encounter a stressor, we have a stress response, and then we come down and we recover. That's on the top. But if there are repeated hits, because of the kind of context in which you live, you stop being able to adapt to those stressors. You're constantly in a stressed situation, tremendous wear and tear on the body. Okay, next slide, please. So Dr. McEwen's idea was that you could, even in healthy people, they may not have high blood pressure per se, but if you looked at various factors in them, how their insulin is doing, is their blood pressure a little bit high? What is their body mass index like? And you could get a portrait of a body that's having too much wear and tear on it, even though from a clinical level, it's still healthy. But these subclinical levels are indicating that stress is having an effect on the body, and likely long-term is Dr. McEwen's argument on health conditions. Next, please. So hold that in your mind. So that is, we've got maternal mental health, obviously affecting her. We must address that, or whatever gender the person identifies with, also getting into the body through wear and tear. Now we're going to look at what that might mean for the offspring that's in utero. This is the developmental origins of health and disease model, also called prenatal programming. Next, please. This is how the first 9 months shape the rest of your life, is another way to think about this. Go ahead, this concept. Next, please. So this work comes from David Barker. He suggests that many fetuses adapt to a limited supply of nutrients, and in doing so, they permanently change their physiology and metabolism. And these program changes get into their bodies. It's like the wear and tear on their bodies in utero that might have implications for their future health as adults. There's been a tremendous amount of research in this area. What I want to emphasize here is he's looking at nutrition, and you're going to go next, next, next pretty quickly, because I have some, you can do next, next, next. Yeah, we're going to keep in mind the idea of adaptation. Perfect. Oh, go to stress, please. Thank you. Okay, so what does it mean? We could look at maternal nutrition and what that means for the fetus. It's also going to be affecting her, the stress of not having enough food potentially, but really just taking the idea of stress or depression or anxiety in pregnancy. That also is a biological experience for her. It is wear and tear on her body. Her body is the developing fetus's environment. And what is that going to mean for the developing fetus? Not just nutrition, as Dr. Barker was looking at, but stress and anxiety and depression. What does that mean for the developing child? Next, please. So in doing this, I want to be very careful that we do not blame the mothers. And next slide, please. When we look at stress, because a maternal experience such as stress or depression or anxiety, certainly it's not anybody's fault, but also these experiences, the stressors that can be contributing factors to feeling stressed and anxious and depressed are not randomly distributed in our society. So we really need to look to society for changes of what is so much pressure on pregnant people, and it's not randomly distributed. There's certain groups who have more of it, and we know this. Next, please. So stress and birth outcomes, there's something called the secondary sex ratio, and that is the ratio of males to females born, and generally more males are born to females. But in times of significant stress, fewer males tend to be born. This is thought to be that strong males survive then, and frankly, we don't need as many of them from a biological standpoint to have reproductive success for the species. Next slide, please. So females, when they're responding in utero to a lot of maternal stress, they tend to have a reduced weight at birth. And then later on in life, they show some neurobehavioral effects. Next, please. For males, they tend to weigh more at birth when there's a lot of stress in their mother's lives. They have higher mortality rates from stillbirth and neonatal death, and they have higher rates of preterm birth. And then they tend to show neurobehavioral problems earlier on in development. Next, please. So we can look at this females in response and their adaptation to maternal stress. They make early adaptations, and the adjustments come at a cost where they have later psychopathology, neurobehavioral problems later on. Next slide. Males, in response to maternal stress, fail to make adaptations to the altered environment, and their survival rates are compromised. And when they do survive, they show earlier neurobehavioral effects earlier on, and also higher rates of preterm birth. So taking these ideas, we're really putting this allostatic load, the mental health condition of the pregnant person, an allostatic load model of the wear and tear on the body, and then what are the birth outcomes from a developmental origins health and disease model, that prenatal programming. What are the outcomes on the offspring? This is a paper we did a few years ago that I wanted to share on this topic. Next, please. So what we did is we did a data-driven approach. We had 27 different variables, and we said, do the pregnant people differ on these variables by some groups? And we ended up with 3 different groups. One is healthy in purple, one is psychologically stressed in red, and one is physically stressed in yellow. And all the variables are put on an even scale, so they're all at 0. But what you can see is the yellow lines, that's the physically stressed group. They have slightly higher blood pressure, slightly higher BMI, slightly more calories a day. Psychologically stressed are higher in stress, depression, and anxiety. And you can see the purple group pretty much tracks the zeros. Now, these are all healthy pregnancies, healthy pregnant people according to their medical charts. Next, please. What we also saw is compared to the healthy group, the psychologically stressed group, this is the social determinants of health, higher percent were Latina, lower education, lower income, more insurance was by Medicaid. They had more prior pregnancies with adverse outcomes. Both the stress groups had higher rates of childhood trauma. So possibly the wear and tear on their bodies started way before they became adults and started thinking about having children. Next, please. What we saw in terms of outcomes was really quite dramatic. That the physically stressed group had about 20% preterm birth. That's twice the national average, around 10%. Psychologically stressed was around just lower than 10%. And the healthy group was about 5% rate of preterm birth. So what we really take from this is if we could address these 2 different kinds of manifesting stress, physically and psychologically, if we could address that in pregnant people, imagine how we could get the preterm birth rate to be really lower. Next, please. We also saw a dramatic difference in that secondary sex ratio. So let me walk you through this. If you put the purple together, so the males, there was a much higher rate of males in the healthy group, about almost nearly 60% to 40%. And what you're seeing to females, excuse me, so you've got 60% males and 40% females. That's way off from what the secondary sex ratio should be. And then the converse of that is that there were more females to males born in the stressed groups. Presumably what's happening is the women are not carrying males to term. We're leading these very stressed lives. And the flip of a coin, these pregnancies are females and they carry to term. Next, please. We also saw that the 2 stress groups had higher rates of fetal demise, so fetal death or baby death. And again, the healthy group had almost none. Next slide, please. So how much stress? So this is a perceived stress scale, and you can see the red group was the highest in that stress score that I've circled here. Next slide. With some other work that we did in another paper, we were able to see that when we diagnosed women with depression or comorbid anxiety and depression, they had about the same rate on the same scale, about 26, 27 on this stress scale, leading us to think that how much stress matters is really in women who are pretty stressed and also potentially having a depression or anxiety that's at that diagnosable level. Next slide. This was true for depression as well. Next slide. Thank you. We're seeing higher values in that depression for the psychologically stressed group. Next slide. When we look at the numbers, it's about 14, 15, looking at some other literature. We can see that how much depression matters. They're in a mild to moderate depression, and it's having it not only an effect on them, but we're seeing it in the birth outcomes. Next slide, please. And we really need to keep in mind there are these health inequities, that Black babies have much higher rates of poor birth outcomes, as was obviously discussed in the film, and we're seeing here on this chart from 0 to 3. Next slide, please. Now, interestingly, in a little bit of something hopeful, we see this secondary sex ratio such that, it's the males are really not at the level they should be at in terms of the birth, their numbers in the stress groups. Next slide, please. But we found an interesting association, next please, in terms of we looked at social support. This is a complicated analysis. The take-home message here is that, and if you do the next here, is that ways of having social support, if you can click next, please. There you can see on the top here, we've got appraisal, which is your overall valuing of you have social support in your life. How much do you feel you belong to other people? You have a community. And then tangible, do you have people who can do an errand? Those are the three variables that most differentiated the groups, the two stress and the healthy group. And you can see that now on the upper left there, where from that 0 score, you can see that the three groups really differentiate the most on social support. So then we took that and asked the next question. Next slide, please. Where the odds of having a male baby got higher the more social support you had. So indicating that these are modifiable experiences, and those with higher social support, even if they were stressed, were able to carry a male to a healthy outcome at birth. Next slide, please. So we're taking these data and doing a study now that's supported by the National Institute of Minority Health and Health Disparities, looking at stress phenotypes in preterm birth and going to a cellular and molecular level to understand this allostatic load, that wear and tear on the body, affecting birth outcomes and potentially helping to explain racial and ethnic disparities in this outcome. Next slide, please. So if you remember, these were the differences in the preterm birth rates in what I showed you before. When we divide our data, if you can click next, please, by being Hispanic or non-Hispanic, you can see that amongst the Hispanic birthing people, the group differences in preterm birth rate are much stronger, indicating than they are in the non-Hispanic group. There's a greater range, indicating that stress may be particularly meaningful for Latinas in understanding risk for preterm birth and potentially for Blacks. We didn't have Blacks in this sample. Next, please. So that informed us to look at allostatic load, but again, looking at mitochondria, which is the engine of our cells. So we're really at a cellular and molecular level. Mitochondria contain their own genome, the mitochondria DNA, and it's actually inherited from the mother. Next, please. And this is particularly interesting and really relevant for preterm birth because preterm birth has an intergenerational impact to a certain extent. So mothers born preterm are more likely to give birth preterm. And this seems to be potentially more so true in Black women. So is it possible that the wear and tear on the body of stress over a generation gets into the mitochondria DNA and affects that woman's birth outcome and then her daughter's birth outcome in the next generation? Next, please. So this is a very busy slide, but really wanting, if you go out from the left, so reading left to right, we've got our chronic stress. We looked at insulin resistance and functioning before in our allostatic load model. Now in the middle of the slide, again, we're going to the molecular and cellular level. We're looking at epigenetic variation to try to understand an outcome, which in Bruce McEwen's model was having diabetes or physical and cognitive decline. But here in our study, we're going to be looking at preterm birth or gestational age of birth. Next, please. So again, our study is wanting to look at these stress phenotypes related to preterm birth to help us understand racial and ethnic differences in these outcomes. We're looking at a mediator of the biology, what this wear and tear on the biology in terms of mitochondria functioning. And then our last aim is building on that positive finding we had of social support. So if there's some birthing people who have lower stress over pregnancy or they have greater social support, can we actually see that on a biological level so that their mitochondria, there's greater energy in the cells, and that would give us a hope on a deep biological level that we can make these psychosocial adjustments, see the change in biology and hopefully in the birth outcomes. Next, please. So last topic here, and I know I'm running a little bit over, is what are the implications of this kind of work? And of course, the really, again, powerful movie we just watched. What are the implications for the prenatal care ecosystem? Next, please. So one is the American Academy of Pediatrics is taking very seriously that toxic stress affects children, it affects multi-generations, and it's their part of the work that they should be doing. Just in a broad statement, I think obstetrics and the ecosystem caring for pregnant people needs to be taking seriously toxic stress and make it part of their work. Next slide. Mental health has to be available and accessible and affordable. We have an embedded service accepting most insurance plans, women's mental health at OB-GYN. We do address toxic stress as a treatment focus independent of a necessary having a mental diagnosis. We really want to address stress to improve mental and physical health. Next, please. I think we need to be doing much more preventative work. We have some work in this area, as do other groups. Really important to be preventing mental health issues. Next, please. There's a lot of such important work in this area of how to have an anti-racist environment in all environments we're in, particularly in obstetrics care. And I'm sure other people are reading these kind of papers. We need to really be having that change the culture of obstetrics, what's being outlined in these kind of papers. Next, please. In general, we should transform the prenatal care ecosystem and think about the psychological birth of the parent. Again, that could help us prevent mental health conditions. Helping people plan for their daily lives. Who's going to give you the support? Is it going to be a doula? Is it good to have your family around? Is that more adverse for you? How are you going to sleep? Do you really use physical activity to cope with stress? That may be difficult for you. What's going to replace it? How are you going to decompress? Next, please. We can help people manage expectations, allowing that there is loss in becoming a parent and room for those feelings. The identity shifts, partner relationship declining, getting used to expecting the unexpected, time not your own. Next, please. Helping people intentionally reflect on becoming a parent. If they've had a traumatic childhood, this can be very important work to do. Next, please. And spiritual, religious, and ancestral sources of support should be part of the conversation of helping people who are birthing people, their partners, transitioning to parenthood. Next, please. So last thoughts, a life course and intersectional perspective is essential for researching and treating maternal mental health conditions. A person's mental health during pregnancy and the postpartum period reflect the life that they've been living and has lived in the social economic context of their lives. These aspects of their lives get under the skin and have wear and tear on the body. When we treat a person's mental health issues and overall well-being, we also are helping the next generation. Next, please. So this is our lab, the Perinatal Pathways Lab. Next, please. And pictures of folks who, this is obviously research and clinical work is, very teamed effort, which is a wonderful aspect of it. Next, please. And just wanting to thank some of our funders. And next, please. And really thank you very much for engaging with me in this talk. Thanks.